afternoon, everyone, and welcome to the 47th installment of the Stop COVID Deaths webinar series brought to you by the University of the Philippines. Magandang hapon po sa lahat at kung nasaan man po kayo sa sulok ng mundo. I'm Dr. Raymond Francis Sarmiento, Director of the National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Today is Araw ng Kagitingan, wherein we commemorate po the fall of Bataan and also the sacrifice of all of our heroes po sa araw na ito. And first and foremost that comes to mind ngayon po sa ating pandemic ay ang ating mga frontline healthcare workers. And a part of that also is to try to understand ano po ba ang nangyayari ngayon at ano po ba ang mga pwedeng mangyari sa mga susunod pa pong mga buwan. As always po, I'm very happy and proud and honored to share hosting duties with our adjunct research faculty at the National Telehealth Center and also the Special Envoy of the President for Global Health Initiatives, Dr. Susie Pineda Mercado. Dr. Susie?
Hi Raymond, magandang araw po sa inyo lahat po ng mga nakikinig, those of you who are watching us on YouTube, on Facebook, and on the playback. And Raymond, how many webinars na? Sabi mo 40 what?
47.
47. Okay, we have been together for 47 weeks. And I know a lot of you are having great difficulties. It's a difficult time now. I think from the beginning of the pandemic, we have not seen this level of transmission of SARS-CoV-2. And we wish we had a crystal ball to kind of see what could happen in the future. But as we always say, laban lang tayo, di ba? We're here together, we're here to support you, and I just like to thank all of you who have regularly been listening and joining to this, joining this webinar series where we try to bring you the very best of our health professionals. And as Raymond said, we truly appreciate what everyone is doing. We know how difficult it is for you, the doctors, the nurses who are watching, the staff, the pharmacists. Napakahirap talaga ng sitwasyon ngayon. But we don't lose hope. We are here. We're gonna slug it out, and we are going to succeed. So we're not gonna give up hope. We're going to continue to do what we need to do, and tulungan tayo. Let's help each other. So today we've got very good speakers who will enlighten us, who will tell us about trends, who will tell us about variants and treatment and all of these things that we need to focus on. There's a lot of noise out there, parang ang daming misinformation, but when you're with us, you know that you've got credible speakers who really prepare before they come here to talk to you. So welcome to the webinar. And so Raymond, here we are. I think, okay, so before, Raymond has some announcement, but before that, actually, I do have an announcement from TVUP. So let's go to our special announcement for everyone.
Do I have strength to carry on? But God, how long must this go on? And if you're here to keep me strong, I'm here to hold the line.
Okay, so congratulations to R.D. Lopez who wrote, you know, that music that we play at the end of the webinar is an original. And nakikita niyo yung parang merong guy dun sa ending na parang gumaganon siya. Yung anak kasi niya frontliner, no? He wrote this song, I Will Hold the Line. I'll Hold the Line. And it just won an award. Go Further Changemaker Awardee in the Henry Ford Awards for this song. So we are so grateful to RD for allowing us to use this song, and it's become our battle cry. We're going to hold the line, and we're very proud and honored that you have received this award. So congratulations, RD. Okay, over to you, Raymond.
Thank you, Dr. Susie, and congratulations po ulit kay Sir R.D. Lopez for that Henry Ford Award. Very well deserved po at maraming salamat po sa pagpapahiram ng inyong kanta para sa ating webinar series po. We are now numbering a little over 1,200 participants in this Zoom webinar. Pero dun po sa mga gusto pa pong sumali, please invite them, please encourage them to log into the Zoom webinar. For those who are medyo malakihan po ang pagpapanood, we are being live stream po in 3 Facebook pages. That's the UP System po na Facebook page. That's the TVUP Facebook page and the Stop COVID Deaths Facebook page. Yun po ay dagdag po sa ating YouTube na live streaming din po. And all of our recordings, all of our 46 previous webinars, pati na rin po ito pagkatapos po nito, you could watch it in the playback dun po sa TVUP channel po nila sa YouTube. I'd also like to take this opportunity po para pasalamatan ang very hardworking team behind the Stop COVID Deaths webinar series. Without each and every one of you out there po, hindi po mapapangyarihan itong ating learning series na ito, and we hope that we could sustain this. Sama-sama po tayo as we try to learn more and more about this virus and how to, well, essentially get through this pandemic po. Over to you, Dr. Susie.
Okay, thank you very much, Raymond. I think what we're going to do now is we are going to launch our poll. So you remember we always have a poll, which is, you know, we want you to have some takeaway messages. And so we're going to launch the poll. Of course, the poll will ask about where you're watching from and so on. So I'm handing over to Raymond for this part. Raymond, go ahead.
Thank you, Dr. Susie. As always po, no, we want to be able to get sort of the demographics for all of our participants dito po sa Stop COVID webinar series. Ang unang-unang katanungan po palagi ay saan po ninyo ito pinapanood? What place are you viewing this webinar from? The options po are, well, the regional options are as follows: Metro Manila, Northern and Southern Luzon, Central Luzon, East Visayas, West Visayas, Central Visayas, Northern and Eastern Mindanao, Western and Central Mindanao, Southern Mindanao, and outside of the Philippines. Alam naman po nating lahat na marami po. At meron pong mga nanonood po sa atin abroad at sa labas po ng bansa. For those who are in the webinar po, I'd like to take this opportunity to greet our attendees who registered and have logged in all the way from Lamut, Ifugao in Cordillera Administrative Region, from the West Visayas State University in Iloilo City, the Northern Samar Provincial Hospital in Catarman, Eastern Visayas, and the South Davao Medical Specialist Hospital in Padada, Davao del Sur, as well as the Surigao Doctors Hospital in Surigao City in Caraga. Internationally, we also have attendees po, no? At least those who have registered from the Institute of Biomedical Sciences, Academia Sinica in Taipei, Taiwan, from Universitas Advent Indonesia in West Bandung, Indonesia, ITM University Gwalior in Betaya, India, those from Singapore, Hong Kong, Ho Chi Minh City in Vietnam, Sungai Petani, Malaysia, Riyadh, Saudi Arabia, and Najran, Dubai, United Arab Emirates, Muscat, Oman, from Bonifacius Hospital Lingen, Germany, medyo ano po, no? No pun intended with the name. Troy, Michigan, United States, Farmington Hills, Michigan, Geneva, Illinois, Lexington, Kentucky, Niagara Falls, Ontario, Melbourne, Australia, Canberra, Australia, New South Wales, Australia, Auckland, New Zealand, American Samoa, and this is the very first time we are also being joined by someone from Diego Garcia in the British Indian Ocean Territory. So maraming salamat po sa inyong pakikinig, panonood at pag-participate dito sa ating webinar. Number 2 po, question is what is your line of work? Most of our participants, those who have logged in are from the medical and nursing sectors po, no? They have comprised nearly 60% of all of our attendees. Hopefully, you'll be able to key in your answers. And then we move on to our questions po. Yeah, question number 3, it states, how much more transmissible is the B117 variant? Ito po yung unang nadiskubre sa United Kingdom po na variant. Magano po ba siya nakakahawa, transmissible po? 26%, 56%, or 76%? Those are our options or choices. Number 4, the economy. can only recover if the public health crisis is contained. Only have two choices, either true or false. And number 5, our last question, which variant of concern ang una pong first discovered in the Philippines, B117, P3, or B1351. So for those who are still trying to key in, I'm seeing a whole lot more of our 1,400 plus attendees participating. Paki-input lang po ito. And may I ask TVUP po to flash on the screen yung pong ating certificate. Ano po ba ang itsura ng ating certificate? There you go. For those who are asking. So ang sequence po kasi ng ating webinar, it's usually someone, we have our opening remarks speaker, we have all of our main discussant or discussants, our reactors, and then we go into a Q&A panel discussion. If you have spent at least half of the webinar duration dito po sa ating Zoom, you will be eligible to receive this certificate and also a copy of the presentations po of our speaker. So hopefully, you'd be able to stay on at the very least po 50%, pero sana po the entire duration of our Zoom webinar. For those who are asking, we have already distributed all the certificates for the past 46 webinars. So if you feel that you should have received one at hindi po kayo naka-receive, please let us know through stopcoviddeaths@up.edu.ph. Over to you, Dr. Susie.
Thank you very much, Raymond, for that, and for all of you for participating in our survey. And we're gonna get some answers to those questions. Okay, so right now I'd like to welcome our guest who's going to give opening remarks. And recently we have been inviting people who are not medical doctors. You had Mahar Lagmay the other day, who's actually a geologist. Today we have an expert in economics and a professor of the UP School of Economics. I'd like to welcome Professor Toby Monsod. Hi, Toby, welcome.
Hi, Susie. Hi, everyone. Thank you for inviting
Yeah,
me.
so,
I'm not exactly an expert. I'm an economist.
Toby, you're an expert. Okay, Toby and I go back a long way. And
many lives ago.
Many lives ago. And I think, it's very interesting. We were working together on disasters when we were in our late 20s. Is this correct?
Yeah.
Okay, so it's like about 5 years ago, right?
Pinatubo and all that. Yeah.
Yeah, so we were working together on disasters. And she was working with Caritas Manila. I was working with the Kapwa Ko Mahal Ko Foundation. And I remember we went to flooded areas in Eastern Samar. You remember this?
Yeah, Northern Samar, Katarman.
So we were together on the ground in some of those times when people were stuck on top of roofs and we couldn't pass through roads because of landslides, because of the earthquake and so on. But I can't imagine, Toby, that we would be working together again now because of this unthinkable disaster that we're in. I mean, at least in the past, those were kind of localized, right?
Yeah.
So
weather-related, local.
Diba? Parang we could, there were parang parts of the country are spared so that help can be given to very local areas. But I think you're gonna talk about this, no? That the Philippines is not, that the COVID situation is not uniform around the country. I'm not gonna preempt what you're going to talk about. But anyway, thank you for joining us. And guys, Toby's been publishing some articles on the economic side of COVID-19, and she's been talking about health and economics. And I think we should not let this opportunity pass that our country does not put in the proper investments in public health. So sabihin natin dito sa webinar, lahat ng talino ng Pilipinas kailangan nating gamitin. Hindi lang yung talino ng mga nasa health sector, pero pati sa ibang mga larangan. Kasi ang solusyon dito ay maraming maraming iba-ibang sektor talaga ang kailangan magsama-sama at gumawa talaga ng plano para hindi na maulit ito. Anyway, enough of that, but welcome Toby, and please give your opening remarks. Go ahead.
Thank you. Okay, good afternoon, everyone. This is taken from a publication we did have sometime in November last year, myself and a colleague. Okay, at the onset of the COVID-19 crisis, it was thought that strong macroeconomic fundamentals would carry the day for the country. We were coming from about a decade of high and robust growth. Our credit ratings were at their highest ever. Our fourth quarter GDP growth in 2019 was second only to China in the ASEAN 3+3. Thus, in mid-March, but March 16, 2020, that was like...
Toby, hold it. Do you have a presentation?
No, they said no slides.
Okay. No.
Yeah.
Go ahead. I was wondering if you had slides.
Yes, sorry. You have to do slides. Yeah.
No, you don't. Sorry to interrupt. Okay, go ahead.
Sorry, yeah, okay. So in mid-March last year, economic managers reassured us that economic fundamentals are on our side, and that even under the worst possible scenario, the Philippines will grow in 2020 and in the medium term by about 6%. So this was when the lockdown happened. So that's like the famous last words, right? This has clearly not happened. By the second quarter of 2020, we had a contraction of about 16%, which is our lowest quarterly growth in 4 decades since 1981, and the second lowest in the ASEAN +3. We were also predicted to have the worst projected economic growth outcome in 2020, the sharpest reversal from country performance in 2019 among our neighbors. So the question was why? Why, despite strong economic fundamentals, did the country do so poorly? Our managers largely blamed or accounted for this by describing the strict community quarantine imposed in March 2020 that was extended until the third quarter. However, this is a somewhat circuitous argument because the lockdown precisely suspended economic activity. It restricted mobility of people. We couldn't go out, people couldn't work, etc., in order to hold the pandemic at bay and buy time for the health system to organize itself. In other words, the lockdown did not cause the economy to contract. Rather, the economy was contracted. Activity was suspended as a response to the virus. Rather than blame the lockdown per se, a colleague and I had a different thesis. We noted that the Philippines version of the lockdown seemed to be the longest and most stringent in the ASEAN +3 region. Other countries, Vietnam and even Singapore, South Korea or China, did not use such an extreme measure, nor use lockdowns for prolonged periods. And so we posed the hypothesis, rather than the timing, intensity, or length of a country's lockdown per se, do the different capacities to detect and respond to the COVID-19 outbreak account significantly for the different economic outcomes among countries in the region? Sadly, we found the answer was yes. Implementing a cross-country model, we found that stronger national capacities to detect and respond to emerging outbreaks are associated with better short-term economic outcomes. For the Philippines, better prepared laboratory systems coming into the crisis could have saved up to 3.6 percentage points in lost GDP growth forecasted in 2020. What does this mean? This is equivalent to about 700 billion pesos. So if we had just done our homework when everyone was doing that homework in the early 2000s, and if we had listened to our own experts that we had to be better prepared for emerging outbreaks, perhaps we would not have suffered such a contraction in the economy. We also found evidence that the traditional channels via government spending to increase output and stabilize the economy are overshadowed by the importance of having specific core capacities precisely to detect and decisively respond to the COVID-19 pandemic. Put another way, if COVID-19 is not first well contained, then government spending aimed at other things may not matter for economic recovery and could even make things worse. The implication is clear. Health system capacity must be prioritized over and above other types of spending, including build spending. Unfortunately, the budget for 2021 does not quite reflect this. If I'm not mistaken, the 2021 budget decreases the budget of the DOH and other related items by about 25%. That may not be as accurate as before, and increases allocations to DPWH and DOTR for infrastructure spending. And now we see NCR again in an ECQ, but this time without allocations for any sort of ayuda to households. In other words, we're back at the relief stage, and we don't even have that. We don't even have recovery budget, much less relief budget. What is our challenge today? We need to convince officials and stakeholders who are concerned for the economy and for economic recovery to focus on capacitating public health systems so that we can get out of this hole. This is a big ask because they're just not accustomed to thinking in that way, right? But it would help to identify more precisely what capacities to invest in as a matter of priority, in what sequence and where, and at what level of the public health system, national, provincial, city, municipal. Clearly, the crisis has proceeded at different speeds and intensities across the archipelago. And so it may not make economic sense for all regions or cities to invest in the same capacities at the same time, in the same sequence everywhere. In other words, a one-size-fits-all solution doesn't make sense. So given budget and time constraints, for instance, should all provinces and cities be investing in a vaccination rollout now? Would it be more efficient and effective, for instance, for some regions and provinces to focus on developing better contact tracing infrastructure precisely to avoid what has happened in NCR? I hope this webinar can help us answer these questions. Thank you.
Okay, thank you very much. That's Professor Toby Monsod of the School of Economics of the University of the Philippines. And we're going to keep, Toby, you can stay, right? So Toby will be with us in the panel. And we have a Q&A box over there, which, you know, you can put in questions there. And we're actually going to ask our panelists to answer questions that come up. So thank you so much, Toby, for that that framing. I think you know, in this webinar we usually talk about more of the medical and the health and the public health side of stuff, and occasionally we have had speakers like you. We had Professor Pernia also speak at some time on the economics of it, and I think in the future we have to do more of that. So thank you so much for those opening remarks. All right, so we have a person on the street set of interviews that TVUP prepares for us on the topic, and our topic is you know, COVID. Teka nga, ano bang topic natin ngayon? The entire topic is what are the scenarios for the next 12 months? And I think we are all, it's a good thing to be forward-looking so that we don't get mired in the difficult situation we are in right now. So TVUP has done some interviews. So TVUP, please take the platform.
More than a year na yung kaso ng COVID natin at hindi siya bumababa, siya ay pataas. Palagay ko ang kailangan nating gawin ngayon ay magtulungan na talaga ang government at saka ang mga mamamayang Pilipino.
You know, give it to science. Actually, yung what is happening now, give it to science, data analytics.
Dapat i-maintain the health protocols such as social, physical distancing, frequent washing of hands, face shields, face masks.
Huwag masyadong lumabas kasi ayaw nating ma-expose natin din yung sarili natin, yung family natin.
If it's not really so important, never go out na lang.
Kasi ito ang sa tingin ko ay malaking contribution to prevent or to minimize the increase of the virus, the spread of virus.
Maging truthful lang tayo when kapag alam nating may sintomas tayong nararamdaman na pwedeng related sa COVID-19.
Kailangan gawin ng bawat isa ang responsibilidad nila para malabanan itong pandemic na ito, itong COVID-19.
The people and the government, the national government, ang tao sana ma-realize na tao din ay kailangan tumulong para ma-realize ng government ang kanilang mga objectives.
DOH should really do their jobs. Huwag yung, di ba, parang ang mga namumuno, iba-iba yung pinapalabas. Vaccination should be sped up.
Kailangan nilang i-improve ang kanilang mga procedures, i-improve ang kanilang mga protocols, i-improve ang kanilang testing and treating sa mga taong infected ng virus.
Hindi matigas ang ulo ng mga tao. Sila ay pagod na. Halimbawa, sa level ng mga tao, mahirap talagang magstay sa bahay. Nakakabagot na yan, lalo pa sa mga tao na may kulang sa kanila ikakabuhay. Nakakapagod yan.
Ako, later on, hopeful ako na dadating tayo sa point na yung COVID-19, ano na yan, kaya na natin siyang i-manage. Kung ano yung mga natutunan natin sa pandemyang ito. Mababago nito kung paano natin siya kalabanin sa mga susunod pa na panahon.
Thank you very much, TVUP, and to those who participated in those short interviews. We're going to the main part of our program, which is we have our main presenter. Our topic is COVID-19, what are the scenarios for the next 12 months? And it is my pleasure to introduce someone who has actually been working very quietly behind the scenes throughout this whole pandemic. But his work has been so powerful. And he's an epidemiologist. He's currently professor of the Ateneo School of Medicine and Public Health. And he's the co-founder and senior technical advisor of EpiMetrics. So Dr. John Wong is an expert in many government panels when it comes to epidemiology and even in the assessment of medications or drugs that are used in the country. So I'm very pleased to welcome John. Welcome to the webinar.
Thank you, Susie, for that kind introduction.
O sige, John. Kamusta na ba? Kamusta na tayo?
There's a short version and then a long version that I will present later.
How about, okay, my short version is, how are you doing? I mean, are you even able to sleep with all the work that you have to do, all the analytics that you have to do?
Since last year, I found that my quality of sleep fluctuates up and down with the level of quarantine.
Oh, you mean more quarantine, more sleep? Ganun ba?
No, more quarantine, less sleep.
Inversely proportional. Okay.
I think, Raymond, that's a common thing, no? Parang, well, for those of us who are working in public health and our frontliners, you know, there's rest, but it's not really rest, no? So anyway, John, go ahead with your presentation. Everyone's waiting for it.
Okay, thank you. I'll share my screen. Can you see my screen?
Yes, sir. Go ahead.
Okay. So I'll talk about pandemic alternative futures for the Philippines in terms of the pandemic. So this is how I'm going to structure my talk now. Where are we now? How did we get here? Where do we want to go? And how do we get there? So just briefly, because I think everybody knows what's happening. so here we are now. No, it's more than twice the August peak that we had last year. And it seems to be peaking, no? But we have to wait a few more days now before we say that it's good news. No? But I also want to draw your attention also to the pre-peak period. No? After the August peak, we sort of plateaued during this period. No? It was lower than the August peak, no? But it never really got down, no? Below maybe 500 cases, no? And we were sort of happy with this low level of cases, no? So just remember this. Now I'll come back to it later. And this is the curve for our cases, no? So as cases have gone up, no, deaths have also started to go up, no. Hasn't reached the peak of last year, no, but it's past the 75th percentile, no, which is a significant line. No? Okay, so how did we get here? No? This is a search which started in February. So one way to understand the pandemic is to look at it as a system. No? So if we look at it holistically, no, we know what health states people are in, and how do they flow, no, from one health state to another. No? So for example, we can divide the Philippine population into 5 or 6 compartments, no, or buckets. No? So most of the population is here. No? We're susceptible, we're not sick. No? People who have to go out, no, in spite of the quarantine, no, have to travel, no, have to go to the workplace, no, they will be exposed, no, because they're mixing with people from other family bubbles. No, most of these people will not be infected, but some will be infected, no, and they become infectious. No? So these people, no, some will be high risk, no. Some will be admitted to hospitals. No, most will recover, but also some will die. Okay, so if we look at this system diagram, no, of the pandemic, no, it becomes easier to understand how we got to where we are. No, so for example, no, susceptible can become exposed. No, so if we want to reduce that, we have to reduce exposure. No, so we have to do things that reduce the transmission rate. No, this is something that we cannot influence. Like I said, it's the incubation period. This is a characteristic of the disease. No? But this is where we can influence things. No, how do we increase recovery rate? How do we reduce the death rate? No, if you look at the other direction, no, the more active cases we have, no, the more susceptible people can be exposed. Okay, but there's also a silver lining. No? There's another bucket, no, or compartment, which is immunization, which we have now. No? So one objective would be to drain the susceptibles, no? So that more are immunized, and then fewer become exposed. No? Let's talk next about R. No, I mean, I think a lot of you have read about this in the papers, no? Or the basic reproduction number, no? Which is a number which measures transmission. Okay, so I mean, we see this in the papers every day, no? RT, no, or the time-dependent reproduction number, no. But more important than the number, kasi the number is actually just an estimate, no. It fluctuates up or down, no? But it doesn't give us much information, no. What is more actionable is to understand what contributes to reproduction or transmission, no. So it's the transmission rate of the virus. It's how many people we have contact with, let's say, in a week, and if we're infected, no, how long we are in the community, no, infecting other people, no, infecting our household or infecting people in the workplace before we're isolated. Okay, so these are the things which have contributed to the increase in reproduction number, no. the variants, low compliance to the non-pharmaceutical interventions. We had a couple of super spreader events starting last December. There's increased mobility because of the opening of the economy, and poor indoor ventilation. We've begun to understand that aerosol transmission is a significant driver of infections. In fact, it was in the newspaper today that CDC finally reversed itself and said that fomite transmission or transmission through objects is not a significant or a major driver of transmission. And then this one, the duration of infectiousness, is influenced by if we're sick, if we're symptomatic, how long before we go for testing, and then how long before we're isolated and quarantined, and how long it takes contact tracers to trace all your contacts and have them quarantined. All of these can either increase or decrease the duration of infectiousness. So let's look at this. Let's start with variants. So this is just a simple analysis, comparing cities with the variants and those without the variants. This was early March, data from early March. So at that time, some Metro Manila cities had variants, the others did not. So of the patients with variants, the symptom onset date, median date was around here, mid-February. In cities with the B117 variant, also known as the UK variant, although we shouldn't be using country names. Those with the B117 variant had the fastest outbreak. This is incidence rate, the number of cases per day. They had the fastest rise since mid-February. Those with B135 or with both variants had the second to the fastest increase in infections, whereas those that did not have variants had the lowest increase. So we know that variants did contribute a little to the surge. But we also notice here that even cities without variants had a surge. So we know that there are also other factors involved. Let's look at those other factors. So this is effectiveness of face coverings, face shields, and face masks. So face masks have an effectiveness of about 70%. If you have good compliance to it, the effectiveness in the population is about that much also, 65 to 70%. Face shields also have the same level of effectiveness if used properly. However, unfortunately, our compliance to the wearing face shield is very low, about 30%. So that at the population level, the effectiveness is also very low. So the combined population of effectiveness of this is about maybe 69%. The target of DOH is for 90% of the population to be wearing face masks and face shields. So if we're able to achieve that, we can actually increase the effectiveness of these non-pharmaceutical interventions to 80%. 80% is quite a high level of protection. It's actually even higher than some of the vaccines. So as you're waiting for your turn for vaccination, just these two things can protect you to the same degree. Let's look at super spreader events. So these are graphs of Google mobility trends. If you own an Android phone, Google's tracking your movement from place to place. And it can tell us at the population level the amount of time people spend in certain areas. So if you look back at Christmas Eve, there was an increase in time spent in groceries and also in retail and recreation. This include restaurants. Later in the next month, for the translation event, there was also an increase in mobility for groceries and also for retail and recreation, but also in parks and transport stations. In contrast, we didn't see the same mobility, no, or rate of people going out, no, for Chinese New Year and Valentine's Day. So did this increased mobility contribute to cases? So this is for Christmas Eve, no? So this was Christmas Eve, no? And we know that mobility increased. No? When we look 5 to 14 days later, no, there was an increase, no, in the reproduction number. So we know that there was a post-holiday surge. How about for translation? No? The increased mobility did not result in an increase in reproduction number. No? And I think this is because this was mostly an outdoor activity. No? So if there was crowding, no, the spread, no, was mitigated, no, by the open space. Okay, how about the duration of infectiousness? Now, how did that contribute to the surge? No? So from last year's data, no, when people get symptoms, no, they usually wait 3 days, no, before they go to the health center or to see their doctor and get tested. No? And it takes 2 days, no, another 2 days to get their lab results. No? The current protocol is that when they're already symptomatic, no, but before the test results come out, no, they're already asked to quarantine. No? So this is probably the more significant period. No? But we know that the infectious period of COVID is 2 days before symptoms and 5 days before symptoms. No? So we know that in these 3 days, they're infecting their colleagues at work or their household members. No? And there's also some evidence that a quarantine is also a bit leaky. No? Not everyone stays in quarantine or is quarantined early. No? Or if contact tracing is not completed soon enough, no? You also have these people who are out in the open, no? While they're possibly infectious. What about testing? No? If we're able to do enough testing, no, we can isolate and quarantine people earlier and shorten the duration of infectiousness. No? This is our positive cases we have now. No? And our positivity rate is about 20%. No? So what that means is that to achieve a 5% positivity rate, no, which is the standard set by WHO, signifying good control of the outbreak, no, we need to be doing 200,000 tests instead. No? So we need to do 5 times more, no, than what we're doing now. So if we can find them, no, we can isolate or quarantine them. Where are the clusters coming from? No? Most of them are still community clusters. No? People found in the household, no, or spreading it in the household. No? But for this February surge, no, we've seen that the number of workplace infections are also increasing. No? So this was December to January for hospitals, government offices, and workplaces. No? So in general, all workplaces. No? And then by February, March, no, this had doubled, no, or quadrupled. No? So workplace clusters, no, are also contributing significantly. Okay, so that's probably how the surge, no, occurred. No? It's not the virus alone; it's multifactorial. No? And each of these factors, no, that I identified, no, contributed a little. No? So where do we go from here? No, or where do we go from here? No, first, short term. In the short term, what will the ECQ accomplish? No? Again, if we use the August surge, no, as a benchmark, no, the number of cases will peak 10 days, no, into the lockdown. No? So yesterday was the 10th day. No? So the next few days, no, we should watch carefully what's going to happen in the next few days. No? However, hospitalizations will peak 2 weeks later, no, because it will take time for people to recover and be discharged from hospitals. And there's already a wave of cases now coming. Even if the cases come down here, no, there's already a wave of cases, no, that need to be admitted. No? So in the short term, no, that's what we're going to expect, no, in the next 2 or 3 weeks. how about in the long term? No, what goals should we set, no, for ourselves? No, if this were baseline, no, so let's say this was January, no, and this is where we are now. No, the variant kasi increases transmissibility by about 56%. So if it becomes a dominant strain, no, right now we don't know yet whether it's a dominant strain, no, because we haven't done enough sampling, no. We've done a lot of testing of the genome of the virus, no, but the sampling has been uneven. But if it becomes a dominant strain, this is where we will be, no, a month after it becomes a dominant strain, no. So we can probably set targets, no. So the rationale is that once the ECQ is able to bring the number of cases down to the pre-surge baseline, we shouldn't be complacent at 500 or 1,000 cases a day. No, we should continue to drive them down, no, and set successive goals, no, so that our baseline cases, no, will be lower, no, and if they're lower, no, even with the variant, no, we will not have the surge that we're experiencing now. So that can be a long-term goal. No? So how do we get there? Again, it's useful to look to go back at the go back to the system model, no? And look at this, no? And we right away we're able to identify several intervention points, no? How do we decrease death rate? No? How do we reduce the number of active cases? No? Reduce transmission or speed up the pace of vaccination? From the equation for R, no, again, no, we find several ways, no, that we can do, no, to reduce the reduction number or reduce transmission. No? Improving compliance to the minimum public health standards, no? Improving indoor ventilation. Also, DOLE has recently released guidelines, no, for improving ventilation in workplaces, no, but it will take time, no, for businesses, no, to install these. No? Avoiding mass gatherings. No? So this is individual behavior. No? This is where the public, the community, and business sector can contribute. But this is for government to do. No? Since people are delaying health seeking, no? There should be active case finding. No? Like what they did in the Rabi in India. No? They did community-based testing. No? This is not mass testing, no? But this is bringing the laboratories to the communities, no? Where we have a lot of cases. It's difficult to do contact tracing now, no, at this scale of the pandemic. No? But we have to prepare that capacity so that when the cases come down, no, we're able to do it better, no, and prevent another surge. No? And we have to be able to measure, no, how efficient are we, no, in isolation and quarantine. So if we look at the pandemic as a system, no, there's this systems. One of the founders of systems thinking, no, Dunella Meadows, no, she said that there are about 9 to 12, no, ways we can intervene in a system, no, to bring it into balance. No. So I'll go through some of them. No. I've color-coded them in terms of effectiveness. No. So these are actually they're numbered in reverse order of effectiveness. So these are the least effective, and these are the most effective. So let's start with the bottom three. No? So one way to influence systems is to manipulate constants, parameters, and numbers. No? So these are providing subsidies, no? Taxes, or setting standards. No? So for example, we can set performance targets, no, for isolation and quarantine efficiency, meaning what % of your positive cases or your symptomatic patients, no, do you isolate in 24 hours? But the reason that this is, no, I mean, we use indicators a lot, no, in the public sector and private sector. But the reason this is one of the least effective ways to influence systems is numbers alone, no, do not change behavior. No? You need other interventions. Second thing you can do is to change the structure of material stocks and flows. No? For example, building new roads, no? Changing the transport networks. No? If you remember a while ago, no? The exposed lead to infectious. No? But if we improve indoor ventilation, no? Not all of the exposed will become infected. No? Some will become exposed but not infected. No? So that's one way of changing the structure of the model. No? However, no, facilities take time to revise and improve. No? Installing new filters, no, new fans, no, will take time. No? Third, no, we can try to weaken or strengthen negative feedback loops. No? For example, one loop, no, that's driving the pandemic is that, as I pointed a while ago, no, more active cases, no, increased transmission because more susceptibles are becoming exposed to these infectious cases. No? So a negative loop, no, that can counteract this growth in cases is to increase and maintain public health capacity to test, trace, and isolate. No? However, negative feedback loops, no, kasi they're usually backup loops, no, backup or reserve capacity. No, when they're not in use, no, or when they're not needed, no, like when we had fewer cases when we had the plateau last year, no, they're frequently dismantled, no, when they're not used, such that when we need it again, no, they're no longer there, no, for us to use. So these are some of the things that indoor ventilation can accomplish. No, so sometimes simply opening windows and doors improves ventilation, or installing fans. No, but it will take time, no, for the standards, no, to be disseminated, no, across business sectors. You can also improve air conditioning by installing these high quality filters, no, MERV 13. And we have evidence that ventilation actually works. No? So there was this case of a gym where a trainer was positive for COVID, no? But none of the gym clients were infected, no? Because they had prevented by improving ventilation and using a carbon dioxide monitor, no? To monitor ventilation. So these monitors are actually available. No? You can buy them online. So I showed this a while ago. No, we also have to multiply by 5 times, no, the number of tests that we're doing. No? But this also presumes that we're able to find these cases. No? So active case finding is also necessary. So while we're in lockdown, no, we have to ramp up, no, again, no, our contact tracing ability. No? So last December, no, we discontinued the contracts of most of the a lot of the contact tracers, no, that were nationally hired, no, and because we ran out of money, no, to pay for them, no. So we started the year, no, with decreased contact tracing ability, no. And then I encourage you to read this article from Rappler, no. It's a very interesting and very detailed story of how, when the surge started, no, we lost control, no, of the number of cases because we were not able to contact trace, isolate, and quarantine, no, and reduce the duration of infectiousness. The second set, no, so these have moderate effectiveness. No? So another way to intervene is to reduce the positive feedback loops. No? So a positive feedback loop is, as I said, no, more infectious cases, more transmission, no? Leading to more infectious cases, no? And yeah, it continues to drive itself. No? So the way to break that is to reduce the infectious cases by isolating them. No? Again, it's difficult to do now, but what's a better intervention is to reduce the number of cases or the number of exposed people, no, that are feeding, no, this positive loop. No? So you reduce exposure of the susceptibles, no, so that it doesn't feed the positive feedback loop anymore. Another way to intervene is to provide more information. No? And this is actually a very effective way, no, or efficient way of doing it. No? Kasi improving information does not cost a lot. No? So, for example, what we've tried to do, no, is to provide some barangay level maps, no, that are visible to the public. No? Unfortunately, that website owned by the DOH, no, it's not very much used. No? Public's not very well aware of it. No? But if they could see the level of the outbreak, no, in their barangay, no, it can change their behavior. No? In terms of not just staying at home, no, but also wearing masks and being more careful, no, or all around. No? So this requires data to be open, and it requires innovation. So we're approaching the more effective interventions. No? So one powerful way, no, is to reset, no, or change the rules of the system, no? Providing incentives, punishments, or constraints. No? For example, so as Toby mentioned a while ago, no, we don't have a single epidemic or outbreak. No? We don't have a national outbreak. No? What we have are different outbreaks, no, at different phases, no, or levels, no, of the outbreak. No? Some are just at the low level, some are at the peak, no, or accelerating, some are slowing down, no? And some are just have gone through a surge, no, and are waiting for the next one. So we need to provide incentives and disincentives for each LGU to rate them in terms of their performance for outbreak control, but also to provide incentives for them, no? Or disincentives, no, if they perform poorly. No? So right now, kasi, although we do track the levels of the pandemic in each LGU, no? Because of LGU autonomy, no? There are no rules, no, as to, or consequences, no, for different levels of performance. No? So accountability, no, is very important. So for example, so this is from the DOH Faster website. No? It's called the Faster website, no? FASSS, no? SSSTER. No? So when you sign in or when you register, you can actually zoom down to your own barangay. No? And it can show this. No? So for example, red are barangays with high level of transmission, but also surrounded by other barangays. No? So these are hotspots. No? And then you also have barangays with no cases, no? But also barangays they don't have a lot of cases, but they're also surrounded by barangays with high levels of cases. No? So if you're a resident of this barangay, no, and you have this information, no, it can change your behavior. So as I said, no, so this is the framework that we use, no, to escalate or de-escalate LGUs, no, in terms of the severity of their outbreak, no, or epidemic. No? So before we allow LGUs to de-escalate, no, we make sure that they have sufficient public health capacity and their case transmission is already at very low levels, no, before they are allowed to sort of pass through a gate, no, and assume a lower level, no, of community quarantine status. No. But this is voluntary. No? There are no rules, no, that will, first of all, even require LGUs to submit their data, no, much less, no, consequences, no, if they don't meet their the standards. And then the last set of leverage points now. This power to add, change, evolve, or self-organize now. In short, now this is the ability to innovate. So, for example, after more than a year of the pandemic, people have been experiencing pandemic fatigue. They've been lax in compliance. They forget. It's more difficult to get yourself to do it. But design thinking is a process where we can rethink or reinvent the way we communicate these messages or remotivate people to adhere to these public health standards. But what's necessary is in the decision-making process, we have to incorporate more diversity, not just a whole of government, but a whole of society approach. We need other sectors to be involved in decision-making. And we also need to allow experimentation and innovation to come up with better, fresher ideas, so that we're not stuck in what we're doing now. So again, one of the more effective ways is rethinking what are the goals of the system. Control the outbreak or save the economy. It's sort of strange also that some people think that we have to balance health with the economy, as if they're opposing forces. But actually, public health or good public health also translate into a bit better economy. So they're not conflicting forces. One of the former economic advisors in the Obama administration said this very early in the pandemic. The number one rule of virus economics is that you have to stop the virus before you can do anything about economics. Okay. And then finally, the most effective way of changing or intervening in the system is to change your paradigm. So once you change the paradigm, everything downstream changes. Goals, structures, rules, incentives. So we need to be looking upstream and looking at the factors which may not directly have caused the pandemic, but made it much worse than comparable countries. So inequity, housing, transport, working conditions. So for example, under ECQ, some people have been allowed to work because they're frontline essential workers, but these are usually lower income workers also, and then they have to take public transport, which is also unsafe. They live in crowded housing, so social distancing is not really something that they can do, and they report to workplaces that may not have good safety protocols. So we need to address not just the social determinants of health, but also the political and commercial determinants of health. So this is a study done on OECD countries. It shows how the economy and public health are related. So these are four countries that did a hammer and dance approach. But what's noticeable is that as deaths started to go down, they already opened up the economy without waiting for it to come down to very, very low levels. So this was a premature opening of the economy. So that stayed low for a while. The economy improved. But since they never really eliminated the virus, it was still there. They had a second, third, or as in the US now, a fourth surge. And by the end of the year, their economy had negative growth. Versus four other, again, developed countries that tried to or aimed for elimination and not just mitigation. So again, they locked down, except maybe in Japan. Japan kasi is an outlier, no? So this is a country that has a culture of wearing masks, no, even before the pandemic, no? So they actually had the safety protocols pre-installed, no? But what these 4 countries had in common was they drove the cases or the deaths very, very low, no, before they opened up, no? And all of these countries ended the year with positive growth, no, except for Japan, no, pero not as bad as for the other countries, no? So good public health, no, also translate into good economics. So again, no, it matters, no, what is the goal, no, of our system, no? So this is the rate, no, the current. So if we look at the vaccination program, no, which is the 6th compartment, no, in our pandemic system model, this is the rate at which we're vaccinating, no? After a year, no, we could probably get up to about 10 million, no? This is the goal that government has set, no? Herd immunity, which is about 70% of the population. But herd immunity is an unrealistic goal, no? For several reasons, no? The duration of immunity given by the vaccines is unknown. Some variants have already escaped, no, the protection of vaccines, no? A lot of the vaccines have decreased protection against the variants, no? And the efficacy numbers that are reported for vaccines is really efficacy against being susceptible to the virus, and effectiveness against progression of the disease, no? Meaning they're good at preventing mild, and they're even better at preventing severe disease and death, no? But we still don't know whether the vaccines are effective in preventing onward transmission, meaning preventing transmission from the vaccinee, no, the vaccine recipient, to people who are not vaccinated, no? So because of that, no, herd immunity may not be realistic at this moment, no? So what we should be aiming for is prevention of deaths, no, and prevention of severe disease, no, which is what we know, no, that vaccination can do, no? And we also know that variants are affecting a younger population now, no? So even the younger population can be at risk for death, no? So we need to aim for 100% vaccination or full vaccination, no? So this is the rate at which we should be doing it, no? So again, no, this is an example of how setting or resetting the goals of the system, no, will affect how the system operates, no? And then this is a diagram or a framework of how we can look at COVID-19 in terms of its upstream, no, causes, no? This is just one part, no, social determinants, no? But you can see that these are weaknesses that we have, no, before the pandemic, no? And these are things that we need to fix, no, at the same time that we're trying to control the outbreak, no, or eliminate the virus, no? And this is my last slide, no? So we have seen that the problems are systemic, no? So it requires system solutions, no, and not solutions that are done in isolation, no, from each other. Thank you.
Thank you very much. Thank you very much, John. I'm sure our audience truly appreciates all the things that you have said and presented. And you know, the number of participants has been increasing over the past few minutes. I think nababalita na nagsasalita si John Wong dito. So John, thank you so much. There are a lot of questions in the chat box, so I encourage you to continue to put your questions in there. And we're going to ask our resource persons to try to answer them while they're not talking or where they have a break. And we have 2 reactors to this presentation. I'm going to turn over to Raymond to introduce our next speaker. Thank you.
Thank you for that excellent presentation. As always, Dr. Jan, I miss going to your house, so I hope we could get together soon thereafter, sir. Anyway, we'll go on to our reactors, but before that, let me give a quick shout out to the UP College of Medicine Dean. Dean Charlotte Chong is in the call also, as well as the director for the UP Manila Community Health Development Program, and all the members po ng UP Manila CHDP, together with Director Anthony Jeronimo Cordero. Maraming salamat po sa panonood. Anyway, may we call on the very first speaker who will talk about from a clinical perspective po, no? She is an infectious disease specialist trained in the United States po, no? And is currently a clinical associate professor at the UP Philippine General Hospital. May we call on Dr. Cybele Lara Abad. Dr. Cybele, please go ahead with your reaction, ma'am.
Hello, thank you so much for the invitation today. And let me just share my screen. Can you see my screen?
Yes,
And
go
my
ahead.
reaction? All right. So thank you so much for having me today. And I have the job of trying to digest Dr. Wong's excellent talk. But I was asked to focus mainly on the variants and why we should be concerned about these variants, given everything that Dr. Wong talked about. So some reflection points that I had to digest as a physician and as a Filipino, a member of society. As Dr. Wong has mentioned, the B1 variant has shown an increased capacity to transmit the virus. And because there's a lot of transmission, so it's the nature of viruses to mutate, to go forth and prosper, to multiply. Other variants are sure to follow. So we have to do something about that before we come up with a super variant. And we'll talk about that in a bit. The increased rates of transmission and the surge, so to speak, of our COVID is really overwhelming. It's overwhelmed the physicians, the healthcare workers, and the hospitals. And it's been very heartbreaking because we've had to turn down, patients we know, our own families or relatives, because the hospitals are full. And so kind of the flip side to that, as mentioned by Dr. Wong, what can we do to solve that? As individuals, perhaps there has been inconsistency or laxity in following protocols. If you were here at the first part of this webinar, there were people on the street saying, pagod na sila, following all these protocols because it's been a year, and that is totally understandable. And for some, it's actually not doable, right? We always ask people to physically distance, but sometimes there's just no space to do the distancing. So we have to correct this. And as Dr. Wong mentioned, it has to be a systems change. And then finally, as a clinician and as a doctor, I'm always thinking, with the emergence of these variants, do our current strategies still work? And will our vaccines work? And this has been also alluded to by Dr. Wong. So let's try to answer some of these reflection points. Just so everybody's on the same page, the variants also have some definitions. So there's a variant of interest, there's a variant of concern, and a variant of high consequence. So simply put, a variant of interest is simply a variant that has changed enough that it is associated with perhaps reduction in neutralizing antibodies, perhaps reducing the efficacy of treatments. But this is kind of just anecdotal evidence, not just an association. It's not yet proven. So there are actually many variants of interest at the moment. But we want to focus our attention on the variants of concern, because these variants have shown evidence already that there is increase in transmissibility, such as the B1 variant, right, with an increase of more than 50% in terms of transmission. It can cause more severe disease, right, such as increased hospitalizations or deaths. So this is what we are concerned about, as the label suggests. But there is also a variant of high consequence, and thankfully we do not have yet any variant that meets this criteria. We will be in grave danger, the whole world, if we have a variant of high consequence, because this will show that the current preventive measures or medical countermeasures are no longer effective. So at the moment, again, we do not have yet any variant of high consequence. So let's focus on the variants of concern. Now, there are actually 3 variants of concern. The B1 variant, which was first discovered in the UK, that Dr. Wong discussed. There's a B351 variant out of South Africa, And there's the P1 variant out of Brazil, right? And these smaller notations here are the number of people in the Philippines known to carry this variant already. This is as of March 20. So these variants are here. And so, as shown by Dr. Wong, this is in part responsible for part of the surge. But as you saw in the graphs earlier, there's also a surge in areas without the variant. So there must be other things we're doing wrong or not correctly, no? So what can we do? So as individuals and as members of society, we can do little things that will amount to big things. So perhaps we cannot do a system change by ourselves, but we can do these little things, no? It just means going back to the basics. So hand hygiene, physical distancing, frequent disinfection, wearing our masks and our shields properly. And now we have a fifth dimension. So hindi na siya apat dapat, lima na siya. So someone has to think of a catchy phrase now. So lima bisa or something like that. Now we have vaccination in addition to this armamentarium. And the way you think about these methods is you want to think about them in layers. So the more layers you have, the more we protect ourselves and others so that we don't transmit the virus forward. So the way to think about it is to think about it in terms of the Swiss cheese model of prevention. I always show this picture when I do lay fora because they seem to get it when now I show this picture. So this is the Swiss cheese slices. So there are holes, right? And you want to plug as many holes as you can. So when you have many layers, you can plug all these holes so that the virus will not come across and infect this person to the right. But note here, and I want to emphasize this as well, there are personal responsibilities in a pandemic. And this is what we're all doing already, no? And this is what we're all tired of doing, but we have to hang tight, no? But there are also shared responsibilities in a pandemic. So you don't think only of yourself, you think of your neighbor, you think of the people around you. So you have to follow, or we all have to follow, quarantine and isolation protocols. We can't escape or jump ship and escape quarantine, for example. We have to abide and be tested or be contact traced. No? And then finally, we added on this layer here in the last slice of cheese is vaccines. And we'll talk about that in a second. Now here in the middle, if you notice, there is a mouse munching at the cheese. So this is who you call the misinformation mouse. And Dr. Susan Pineda Mercado earlier mentioned that ang daming ingay. So there's a lot of noise. And this is all coming from the misinformation mouse. So I think I want to also emphasize that people should follow the science, just as Dr. Wong presented. There's really a lot of science behind COVID-19, and we should stop listening to these rats. So I'll just call them a rat, or the misinformation mice. So we have to be very careful and be discerning in terms of the things we forward on Viber or the things we forward on Facebook. Is it true? Is it fake, or is it a half-truth? So we have to contribute as well in terms of trying not to forward misinformation pieces. So what else can we do to slow transmission? And this, in my mind, is how I envision the virus mutating or the variants. So viral replication is in the order of thousands per day or even millions sometimes, depending on the virus. So the more it multiplies again, the more chances it can form a variant, which are these in different colors. So what you want to do is you want to slow down transmission so that you can prevent emergence of these variants. And you can do it just by doing things that we're doing already. So hand hygiene, wearing your PPEs, your mask and your shield properly, physically distancing if you can, and of course, vaccines. So here's my 2 cents on vaccinations. So vaccines still work, okay? And again, as mentioned, it will decrease the number or the N of the susceptible population, and it will also modify illness, right? So what we want to happen is we want to get vaccinated so that if we get COVID-19, we will not get severe illness. We will just get mild COVID-19, a very mild cold, for example, or a flu-like illness, so that we can also help decongest the hospitals, for example. And in terms of vaccination, we also want to think about prioritization, which we're already doing, right? We're vaccinating the healthcare workers first, the frontliners, and then the seniors who are at risk of very severe COVID-19. So there is some speed or there's some urgency to getting vaccinated. And there's also equity, because I think we have to think about it in terms of the whole Philippines. Everybody will eventually and should eventually be vaccinated, because we want to avoid what I like to think of as a vaccination gradient. Now, again, this is kind of the picture in my mind. So if we have two areas with COVID-19, for example, and they both have a lot of viral transmission, but area 1 is a bit more successful than area 2 in stopping the transmission of virus. So let's say they've been able to curb or flatten their surge. Eventually, because the economy will open up, or because of the loss of physics or the loss of science, there's actually diffusion or osmosis or travel, right, of people from area 2 to area 1. So because area 2 is not very successful in curbing the virus, then eventually area 1 will again be reinfected, and perhaps even be infected with the emergence of a super variant or a variant of high consequence, which is what we really want to avoid at this point. So kind of some take-home thoughts for you to think about in the next few months or the next few days. Even with the variants, our current minimum health protocols still work. So please try and hang in there and wear your masks and wear your shields, and remember to layer up. So if you have to go out because you have a job to do, you have to feed your family, then just wear your mask and wear your shield. The more layers you do, the more likely you are to stop the transmission of the virus, and the less likely you are to be infected yourself. In terms of urgency to vaccinate, we have to vaccinate a lot, as Dr. Wong showed you in the graph, but we have to do it the right way, because we want to also avoid the emergence of a super variant or a variant of high consequence. And as everybody put in the chat box, I also like this line. Now, there's also virus economics. If you control the virus, then we control the economy. And I think that's my last slide. I just want everybody to be safe. And if we are safe, only if everyone else is safe. Thank you very much.
Thank you very much. That was Dr. Cybele Lara Abad. Again, another excellent presentation. Thank you so much for that. Very clear on the variants. And I'm sure I can already see in the chat box there are a lot of questions. So I'm going to ask our doctors to continue to try to answer on the Q&A in the Q&A box. Okay, so we're going now to another reactor, and just a little bit of a backstory. When we started this last April, so our webinar series started last April, the person who helped put together the first set of speakers for the Stop COVID Deaths webinar is Dr. Aileen Wang. We talked a bit about who do we put in a webinar first if we want to have clarity on clinical management of COVID. Remember, at that time, we didn't know. We had very little information, but PGH plunged into research right away and was, as they were going along, modifying protocols and so on. And in this webinar, we did talk about, for the first time, cytokine storms, proning, using, not ventilating, intubating too early, and so on and so forth. And the person who worked on getting those speakers in the early days was none other than Dr. Aileen Wang. So we're very happy to welcome her back. She's professor of medicine at the University of the Philippines and is one of the leading pulmonologists in the country. Aileen, welcome.
Thank you very much, Susie.
Sige, so teka muna, before you start, Aileen, give us an idea of what the situation is like right now at the Philippine General Hospital.
Yes. Allow me to include that sa reaction ko, Susie, later.
Sige, okay, go.
Yes. Sige. So again, thank you for this kind invitation again, Susie and Raymond and the Stop COVID team. And I would like to share this first infographic na binigay sa amin sa PGH group namin. It's been a year since this horror started, and we still haven't awakened from this nightmare. And indeed, yung mga frontliners, they really rose to the occasion, and I think over and beyond what is expected of them, over and beyond their call of duty. And as mentioned by Susie, she invited me to speak at the very first Stop COVID webinar. And can you imagine, number 47 na kayo ngayon? And Susie actually asked me to talk about conducting research during this pandemic, how feasible it is. And I think from the beginning, we already saw the importance and the need for unassailable, indisputable evidence so that it can help us in caring for our patients. And at that outset, we already talked about how we can possibly conduct research. And I think we are fortunate that we have scientists like John who talagang ignores the strong opinions and strong emotions and just sifts through all the noise and just gives us, he analyzes, he looks at uh, what figures and numbers and trends that do not lie so that we know what we can do. So I was asked to give my reaction, one as a clinical researcher and two as a clinician pulmonologist. And ito yung how I feel about John's talk. First, each of his slide I think gave a karinyong brutal outlook. Hindi ko alam kung paano ko English yan, sorry. So I think he opened our eyes to the sobering reality of our current situation. And formerly, at least for me, I really couldn't see the forest for the trees. So if you look at all the social media and all the news, parang nakakatakot all these things, but we don't really know what's happening. And I think yun yung nagawa ni John for today. So, and I also found solace despite being confronted by the results of his big data analysis in that we did see the big picture. And now at least we know now how to move forward. And to quote Aristotle, or probably misquote him, knowing ourselves is the beginning of all wisdom. And I have another favorite adage, this time from George Santayana: those who cannot remember the past are condemned to repeat it. And we're right there, right? One step forward, two steps backwards. So what do we do next for the next year? So how do we stop this? So I thought that John's presentation was factual, it was incisive, it was succinct, it was pretty compelling to me. He was informative. You can really tell that the presentation was well thought out, and there was extensive prior preparation. And I think the most important thing, as I've mentioned, he provided clarity amidst this chaos of all the background noise and misinformation going around. And pero hindi lang negative or hindi lang doomsday scenario. He did propose solutions and they are science-based. He emphasized the need for systems change. And I think for us, even for the layman, we need to think along this way. And if there's one take-home message for me, it's that we need to trust science and hard statistics. Which brings me, allow me to make another last adage na pasabi from Adam Smith: science is the great antidote to the poison of enthusiasm and superstition. So let's talk science. Just to share with you, and I thank Nina Berba for sharing these slides with me. She's the head of our HICU control, so PGH. Just to show you that what happened or what's happening in our hospital mimics what happened in the community. Just what John presented. So in PGH in March, 66% of our healthcare workers got their infections not from the hospital, but from the community or household. And as you can see it from all of these. And ano yung definition ng activities from community? Naghanda po kami sa bahay, yung isang bisita, may COVID pala. Nag-attend ako ng birthday party, nagpunta ako sa Lamay, nag-outing kami, nagpamasahe ako, nag-beauty parlor, kumain sa labas, nag-shopping sa mall, nagpunta ng palengke nung pinapa-quarantine ako. Community spread. And if you will actually see how it affects our work in PGH, those infected co-workers who still work and expose others, they produce the greatest disruption to our operations. So yung call talaga, isolate yourself. I remember Nina sharing one infographic for every healthcare worker was infected. Na-infect niya mga 4 to 5 others. So what happened in PGH, the same as in the community, microcosm within the macrocosm. So as a clinician and as a researcher, what evidence convinces us to prescribe a new drug for our patients? So let me share with you one study that came out early in the pandemic, March last year. 80 admitted patients with COVID-19, they were given drugs A and B. And look, nice results. 83% negative na viral load clearance by day 7, 93% by day 8, and 97.5% showed clinical improvement with a mean hospital stay of 5% and only one death. That makes it 1%. Really nice results, right? So this was actually one of those studies that were released in March talking about the beauty or the effectiveness, quote unquote, of hydroxychloroquine, this time combined with azithromycin. And these and similar studies moved politicians like Donald Trump to talagang try uh, to brasso the arms of the CDC to put hydroxychloroquine there in the guidelines. And actually in our clinical pathways, we actually put it there as well. But many months later, the huge recovery trial came out. It's a UK multicenter. It's a randomized controlled trial. Obviously, you've noticed that the original one did not have a controlled arm. So these were huge numbers comparing hydroxychloroquine with usual care. And what did this study find? So hindi 1% the deaths, at least within 28 days, 27%, much, much higher for the hydroxychloroquine group. And although it did not show overall a difference in the usual care, but what they found, the patients given hydroxychloroquine were less likely to be discharged from the hospital alive. And if they were not intubated at baseline, they had a higher frequency of invasive mechanical ventilation and eventual deaths. And there was some concern about some excess of cardiac deaths. So this was published in a high impact peer-reviewed journal, New England Journal of Medicine. So take note of the difference between a cohort study with no control and a randomized controlled trial. Then let's look at the natural history of COVID. So as of yesterday, 23 million active cases, 99.6% of them have a milder disease. And I would like to quote WHO country representative si Rabindra Abeyasinghe. And as seen by sa natural history ng COVID, for those patients who've recovered, actually more than 95% of them recovered without specific treatment. So if you give that patient a certain drug, that's maingay now, you'd think that that drug actually cured them. And Dr. Abeyasinghe said, this is not science. This is not evidence. So in God we trust, all others must show data. But what kind of data do clinicians trust? And I know that there are laymen in the group. So let me just share with you how we, how we look at evidence-based medicine. We actually have what we call a hierarchy of research design. And based on this, we assign levels of scientific evidence. At the very bottom are the animal and laboratory studies, which we call mechanistic studies. And then next, yung mga testimonials, mga series of cases that show good outcome or poor outcome, and expert opinions. And then the observational studies, case control, retrospective studies, prospective studies. And at the top of the pyramid, they're not as many, but they're the most important are the robust, well-conducted, randomized controlled trials, and the pooling of those results of those RCTs, which we call meta-analysis. Only RCTs can actually or have the ability to control bias and therefore will have more valid results and can truly demonstrate cause and effects in humans indubitably. So this is how we look at it. And ang problema nga, all that noise and all those misinformations going on. And let me quote again Dr. Abeyasinghe, the fight against the infodemic has been even more difficult than the fight against the pandemic. So just to show you how it is in my village, one of our residents actually posted this Facebook group namin, comparing mRNA vaccine with a controversial drug. I'm not going to mention what it is. Pero yung proof niya for effectivity, it's proven to kill COVID in laboratory experiments. Positive trends from retroactive studies and widespread anecdotal evidence on effectivity. And if you remember from my pyramid, those are way, way at the bottom of our levels of evidence. Although yung resident naman acknowledge that there are inconclusive data rather, or still lack of data from well-controlled prospective human studies. Pero since highly effective against parasites, you can give it, and in case you have that, you hit two birds with one stone. So patay si COVID, patay din si parasite. But this is the problem that we have now. And I really think we need to address this by Cybele has actually given all those beautiful steps how we can do this. Try not to share fake news or half-truth news. So how is it like in UP Manila? What are we doing in our group? So in April of last year, I presented the proposals or the studies that we were planning to do and what is the scenario for the next 12 months. I would expect that we'll be able to share already the results of these studies. So these are all sponsored by PCHRD, and what you can actually look at from our study group, we try to see all the salient disease aspects so that we'll be able to understand the disease further and we will know what works. So as you can see, we looked at epidemiology, clinical profiles, outcomes, predictors of mortality, lab-based studies, and then syempre, very important, disease transmission and infection control. I put in yellow the project leaders for each of these studies. And then we're also looking at impact of COVID-19, families and patients mismo. I included here the rapid living reviews of our very own NIH, Institute of Clinical Epidemiology, in coordination with the Philippine Society of Microbiology and Infectious Disease. So there. And then we're doing predictive models. We're trying to validate them and also addressing ethical issues. So the ethical guidelines on COVID-19 crisis level has actually been published already by Dr. Lenny Fernandez et al. And finally, the most important studies looking at diagnostics, the utility of the various biomarkers to detect cytokine storm and predicting hospital mortality and also coagulation parameters, and the randomized controlled trials, those important studies in our very own population. So hopefully by end of next year, we'll have an answer for you on convalescent plasma therapy, IV tocilizumab, virgin coconut oil, we are part of the WHO Solidarity Trial, and we've actually already published the interim results last year. And Nina Berba's doing the Avigan trial. She's the country investigator for this. I did not include here the vaccine studies. We're also involved in them. And finally, among the studies, as we speak, we're actually also developing the program for what comes after COVID. So we're looking at long or long haul COVID, or what we should now call the PASC, and to try and understand and address this and plan for it to help our patients. And finally, I think this is my last slide. In the hospital, what are we doing? So in March, April, we formed clinical pathways to try and to make standardize how we manage our patients at the PGH. And in April of this year, or early this year rather, we actually updated this. We've been updating this continually throughout the past year, and you'll expect that in the next 12 months, we'll still do this depending on what new data appears. So what you will see here in the clinical pathway, we've put here those that have been shown to work by Solidarity and all the other trials, including steroids or dexamethasone for the more severe patients, enoxaparin or anticoagulation that works, and then remdesivir for a certain group of patients. So usually those patients who are moderate to severe in character. And then all the other all the other interventions, hemoperfusion, you will see here, and tocilizumab. So studies also now coming from the recovery trial showing that tocilizumab will be effective for patients with high inflammatory markers like CRP. So that is what we've been doing at the PGH, and you'll expect that we'll still be doing that. And finally, as a last slide, we've had some doomsday scenario, pero may vote of confidence naman. And let me quote one of my favorite IDS, aside from Cybele, of course, Dr. Edsel. How good are Filipino doctors and healthcare workers during the COVID-19 pandemic? World class, better than world class. Our death rate of 1.8% is lower in many countries. So out of the top 30 countries with the highest number, we actually have the second lowest. So at least some hope and some confidence with our frontliners. And I think that's my last slide. Thank you very much. Susie, back to you.
Right. Thank you very much. That was Dr. Aileen Wang, another excellent presentation, and you'll see in the chat box, Aileen, all of the pasalamat, no? Also for John and for Cybele. Okay, we're going to call everybody back now. Toby, Cybele, John, and Aileen. And I understand that Dean Charlotte Chong of the UP College of Medicine is around. Charlotte, you're most welcome to join the panel if you can. Okay, so we're going to now go into our panel discussion. But before we go into the panel, Raymond is going to inform our panelists of who the audience is. So Raymond, please go ahead.
Thank you, Dr. Susie, and thank you to Ma'am Aileen. I particularly like the suspense po. I was actually trying to wait for the naming of that controversial drug. Pero baka next week na natin yan mahintay, ma'am, no? So, okay po. For our poll, we have 5 questions. We'll start with the demographics. 54% of those who inputted their locations are located in Metro Manila po. Next up are those from Northern and Southern Luzon, and then also Central Luzon, with 1% comprising of attendees from outside of the Philippines. As always, majority, ngayon po, 56% of those who are attending our webinar are from the medical and nursing sectors. So yun po ang karamihan ng ating mga nanonood, although meron pong dito po sa others, ako po ay very much excited to tease that out. We have 3 questions. We'll probably try to answer this later na lang po, Dr. Susie. We'll go to the panel discussion before we try to answer these questions po. Thank you.
Okay, thanks a lot, Raymond. Okay, so for our panel discussion, I thought what I'd like to do is because Toby started us off on the economic side of it and how the investments in public health are actually good for the economy. So I'm going to ask Toby to have a reaction and maybe to ask a question to our panelists. So I hope I'm not putting you on the spot, Toby. I'm sure there are questions, that come out of what you heard. So Toby, let me turn over to you.
No, I'm happy. I heard the same thing from John. He calls it virus economics. For me, it's really quite simple, right? It's not about controlling the outbreak versus growing the economy, or even in a sequence. It's not. The first is a necessary condition for the second. Ganun lang kasimple. And I think I think we're seeing that now because we're going, back and forth on all these things. I think what the questions I had actually to John and the rest were things like this. No, for example, with respect to John, because I'm thinking about, okay, so what does this mean operationally, right? What are we talking about? And I got many messages from John. And from an economic viewpoint, we need to prioritize because of budget and time constraints. We cannot just say vaccinate all. We cannot do that, right? And so it's not helpful to policy to say things like that. For me, it's like I'm happy you said something about, testing, and you need the point that our testing must be 5 times more than what we're doing now. That's really important to me. However, I'll also still ask, because the debate in April last year was, are we talking about diagnostic testing or surveillance testing? Because that was the big debate. DOH did not want to do surveillance, which is what we thought as economists was necessary in order to track the dynamics of the pandemic, of the virus, right? Not so much for clinical or diagnostic purposes. And honestly, I think that's what we're missing now. We don't have that, right? Because we never did it. So it's important that we define what you mean by 5 times more, right? So it could be a combination. I'm happy also that you're saying contact tracing, mainly because this group is across the country, right? What's happening in NCR is not happening in other places. And like I said before, I do believe, obviously, that NCR needs to get its act together and roll out, but with the national government, but that as a priority may not be the same as somewhere in the Visayas, right? So the question to everyone, I think from a regional viewpoint or provincial viewpoint, if you had 1 more peso, where will you put it? Would you put it in vaccinations? Would you put it somewhere else? That's the economic question for me, right? And I think that if the DOH, for instance, now, and I'm not quite clear how they're allocating vaccines, I'm not. Is it equal? Because typically that's what they did before. Parang divide by N. Everyone gets something, even if the level of priority is so different across the country. And now, if you're saying that you want to vaccinate a good percentage in order to optimize that measure, right? The instrument is vaccinations. Where would you put that? Would you distribute it across the country? From an economic viewpoint, that doesn't make sense, right? And so I think we need to do that. And from the health, public health people, it would help if you say that this is the general rule, but you have to apply some sort of cost effectiveness or efficiency analysis to say what, where, when, and when, right? That's my and I think the stuff that John was talking about and others, me kasi, it's like, yes, systems thinking, but systems thinking itself must be unbundled. Some is short term, some is medium, some is long term. Whenever you make recommendations, not only do you disaggregate by geography, because we are just, as John said, we are different pandemics happen, epidemics happening all over the place, but also short, long, medium, and long term, so that we don't get overwhelmed, right? So from what I understand from Susie and our previous discussion, maybe in NCR it is vaccinations because it's happening in congested urban areas. How can you even isolate, right? So maybe that thing in NCR is so different from I don't know, the rest of Cebu province and so forth. So if we can have that, then economists can help, can help parse that. There was a comment in the chat box about, how do you deal with the no work, no pay, right? Because of pandemic. My only answer is, well, government has to provide ayuda. If there's going to be a government imposed lockdown such that people cannot work, they have to come in. The other question was, can we print money to give? Printing money, guys, is a phrase we use. It's one way to raise funds, right? From the Bangko Central viewpoint, there's a technical thing with that. You don't just, print money and then give it away, though. You can. But I think the issue here is our economic managers don't seem to get, and I'm sorry if anyone's in the room, don't seem to get that, yes, we prepared for a rainy day. We were strong before the pandemic. So now you borrow to the hilt. Diba? Your country is suffering. What are you doing trying to monitor? This is the time that you leverage those fundamentals to borrow to the hilt, etc., so that the country does not die, diba? And households do not die. And from an economist viewpoint, remember, for as long as you use the borrowed money wisely, then it will all pay back later on. The issue is if you don't use that borrowed money wisely, diba? Then you won't get the returns later on. So that's, that's what we need to do, right? I agree that if we are in a lockdown stage, we shouldn't even be talking about recovery. It's relief, diba? It's relief. And then you set up for recovery the way everyone's been talking about. Thank you.
Thanks, Toby. John, you want to respond to that?
Yeah, I feel like I was in my master thesis defense.
You kind of are.
John, I want your slides.
I just answered. It's a lot of questions, but maybe I have answers for some of them. No, the testing I mentioned was diagnostic testing. No? So these are people who are symptomatic, who need to be tested. No, so that the decision can be made to isolate or quarantine them. Because we also don't want to indiscriminately isolate people, no, even though they're negative, no. But I agree that surveillance testing is also necessary, no, because one study by the CDC said that in the US, for every person that tested positive, they missed about 4.5 other people, no. I think here in the Philippines, it would be much larger, no. So we might be closer to herd immunity than we actually think, no, because of those undiagnosed people. No? With regards to vaccination, I also did the modeling that Toby mentioned. No? What if we just focus on NCR? Because that's where most of the cases are and most of the deaths are. No? And I didn't look at the economic side, no? But just from a epidemiologic side, no, we actually do save more deaths, no, focusing just on NCR. But the problem is, we're supply constrained also, no. So if we had unlimited supply, no, we could do that and save. I don't remember how many lives we would save, no. But I also looked at the timing of the delivery of the vaccines, no. We won't be getting it in time, no, to be able to do it at that scale. And I agree with you that yung systems approach, no, has to be both prioritized in terms of person, place, and also time. No?
Just to John, so if there's a supply constraint, the more so it shouldn't be just distributed across the country, yeah. If there's a supply constraint, so it's you have to sequence it, and it's not only, and I understand about seniors, but I remember Susie bringing this up. You were talking about this earlier, right after seniors. We should really think about the working age population, right? I mean, parang it's like if you really wanted to do that, shouldn't that be next, right? So my point with the NCR, which you share, right? There is a supply constraint. So the more you have to prioritize who gets it first, the more. So, and yeah, that's all. Thanks.
Yeah, so the government does have prioritization, and they did prioritize saving lives first. No? So these are seniors, but also persons with comorbidity. No? They have, on the average, 1.5 times the risk of death. No? And then the next to go would be in frontline essential workers. No? So I think this group have a lower risk of death, but a higher risk of infection because they're the people out there. You know? So yeah, I think that's.
Yeah, thank you,
I mean,
Toby.
Is it seniors across the country, or is it at least geographically sequenced?
Right now it's across the country.
Yeah.
Yeah.
Well, that's what I mean. I mean, I'm being very cold. It may come out very cold, right? But yeah. The risk, honestly, the risk of someone who's not senior may be higher in NCR than someone who's senior outside. That's my point, right? So that's what I mean, that the national, we cannot just apply national analysis. We gotta go down, right? Because we don't have enough money, we don't have enough supply, and we don't have time. That's a resource allocation issue.
when I did that exercise, my experience was that it's not just an epidemiological or economic issue. It's also ethical, no? Kasi you're already deciding whose lives to save first. Kasi when you prioritize NCR, no, some lives will be lost also in other regions. So parang it needs a wider discussion across a broader group of stakeholders.
No, I agree, John, but you just said in your slide that, masks and shields can give you almost equal protection. I'm just saying, can you, I'm not suggesting that someone is saved first, because there, as you said, there are other measures that could maybe be at, approximate the vaccination, right? So it was in your slide. So I'm wondering, right, if, given the spillovers and given everything else, some hard choices have to be made, but that doesn't mean that you're condemning someone to die. It just means that in the meantime, right, in other places, can we make sure that masks and are available for seniors in rural areas, right? I mean, that's all we're saying. Can you use that first while the supply comes on stream?
Yeah, I think and that's why we entitled this webinar, "What to Expect in the Next 12 Months." No?
Yeah.
In an ideal world, we would like, everyone to have access to everything, ideally. But that's not the situation. And in fact, I was going to ask our clinicians. I was going to ask both Aileen and Cybele, because they're seeing it on the front line, right? To describe to us a little bit what they're seeing and what they think the effect is going to be on the system. Because so I get it that we actually know what the trends are. So John has given that to us. I think, Toby, you're talking about what the consequences are of not shifting our prioritization or going more localized. But I think from the point of view of the front line, which I'm going to ask Aileen now and ask Cybele, where earlier we were talking about nurses are leaving hospitals, or, patients are dying in the emergency room. So let me turn over to Aileen and maybe to Cybele and just talk a little bit about, because there's the short term, right? There's the long term and the ideal that we want to do, but there's this right now, we are in a crisis. So what are you seeing and how do you think we're going to mitigate that? So let's go to Aileen first.
Allow me to ask Cybele first because she's a frontliner. She's right there.
Okay, Cybele.
Yes po. So in the front line, visually, it's really parang it's a war zone. The ERs look like a mess. There's too many people in the ER, inside and outside of the ER. This is both in the private and the public health setting. No? So PGH looks the same as the medical city in terms of volume of people, and parang the way they're just waiting outside. Medyo pareho na yun, no? Parang wala nang distinction between private and public hospital. Siyempre meron pa din, but parang just to paint the picture. And it's the recent surge has really stressed the capacity of all hospitals now in the NCR, the big hospitals, to accommodate the sicker patients. So it's been very stressful because it's parang hitting closer and closer to home. I know parang 7 degrees of separation. Now it's closer and closer to home. I know relatives now and colleagues now, we're admitting them, or not being able to admit them is even more stressful because, they call you and they, you try to look for a bed for them and almost certainly hindi tayo successful, no? So that's very stressful. And so may pila na siya yung mga hospital. For example, right now I'm in the PGH ICU. It's just virtual rounds, but we have to triage. There's about 22 people lined up for the ICU just to get in the ICU, but it's full. And so a lot of them, unfortunately, either get too sick or die outside of the ICU or wherever they are in the ER or in the pila. No? So that's how it is. Ganun din po sa private hospital. People are spending 5 days in the ER where they should just be spending hours there. And some of them die in the ER while waiting for their room. So totoo po yung naririnig ninyo. And from a patient perspective, naiintindihan ko po kasi we receive calls, na galit na yung pasyente and nagmumura na. So nakikwento din yan sa amin as frontliners, no? But I understand that because syempre if you have a loved one, di ba, you want to get into a hospital, magagalit ka na sa lahat, di ba? But parang wala kaming choice kasi wala din kaming staff, walang room, literally walang room, walang sulok. Walang sulok where we can place your loved one or our own loved ones. So ang hirap-hirap po talaga. So yung solution, we're always about trying to find solutions. So part of the solutions, we're trying to hopefully, some people are talking to the government and other LGUs kung pwede bang i-step down na yung mga maybe recovering patients, maybe they can just step down to a facility somewhere para mag-open up yung rooms, something like that. Some have even maybe said open up parang field tents, mga ganong type for those who can do that. And also home care. Now, umabot na po tayo sa home care where people who have the means or people who have at least some people to take care of them or help them, parang teleconsult na lang, and then we'll try to help them at home. Parang ganun lang siya. It's that bad. Now these sicker people who should be admitted, we're trying to help at home. So this is how it looks like in the field. It's really quite a mess. So we really need all the help we can get. Ma'am Aileen?
Yeah.
Thanks. Aileen, what do you think? Aileen, what do you think? Where are we going? Where are we going now?
In addition to what Cybele has mentioned, we'll need to consider also with all those increased number of cases, the worry, particularly among us crit care people, the lack of medications, important medications that are starting to run out. And I think we're still fortunate in PGH. We have a very proactive, supportive leadership who see these things, and at least we're better prepared in PGH. But I've seen small hospitals outside of Metro Manila not even having the basic needs, and something for me which was a shock. They should have had at least a year to prepare for this, and you find out they don't even have high flow nasal cannula, etc. So at least for the next 12 months, this has to be addressed. The problems of the variants, I don't think is going to go away. We can try, I think the most important still is to kill the source of those viruses. So we really need to isolate the hosts. It's still very important. I think the priority should be in contact tracing and community isolation. I think we should have those hospitals like in China, those huge tent hospitals, if we can set those up, at least to relieve the tertiary hospitals so that we can really just take care of the moderate to severe patients. So that's my additional take on what Cybele has mentioned.
Yeah, I mean, John also said that, the nag-peak ngayon, and you will see a peak in hospitalizations in 2 weeks. So what do we need to do to prepare for that? I don't know who wants to answer that. John, maybe you should answer that question. No, what's being put in place for this? We already anticipating a huge number of hospitalizations. And, we've got 3,000 people who are listening to us right now from all over the country. What kind of preparations need to be put in place, whether it's in Metro Manila or the outskirts of Metro Manila?
So I think let's also ask John, when do we expect to see the benefits of the lockdown?
Okay.
Do we start seeing it now?
Nag-thesis ka ngayon, John. Sige.
And where is that peak? Is that NCR? Sorry.
Yeah. So if this current surge follows the pattern of the previous surge, no, and just looking at NCR, the peak should have been yesterday, no, 10 days after the lockdown, no, and then hospitalization will peak 2 weeks after yesterday, no, 2 weeks after the peak of the cases, no. Well, with regards to Susie's question of, I think you phrase it correctly now. How do we prepare for the next surge? Because I think it's already too late now to do anything about the way the hospital system has been overwhelmed now. No? We should have prepared for this surge, no, during the interim, no, between August and now. One of the things we realize is that we've been measuring beds and ventilators, no, but now we realize that healthcare workers are actually a scarcer resource. No? They're more difficult to increase in number, and they're more difficult to replace, no? Especially now that there are also hospital clusters. That's all I can say. No? I wish I had better news.
Yeah. Okay, Raymond. Raymond, did you want to ask a question, or did we have a question from the audience?
Well, we have Ma'am Maria Cecilia Polido coming in from our live audience. Ma'am, may we ask you to unmute and ask your question po. It's the most upvoted question in the Q&A.
Nakamute yata rin.
I don't think we can hear you po, ma'am.
Can you hear me?
Yeah, we can hear you now. Go ahead.
Good afternoon. My question is, our government is also pointing out that pasaways are the main reasons for the surge. But I believe that we citizens are not given the means and measures to cope against a massive community transmission. There is poor mass transportation, ventilation, and capacity, no safety net for our daily wage earners, and our administration. What do we do? What do we ask our administration to increase the compliance to health standards and be trustful in reporting possible contacts without being stigmatized? That's all.
Thank you very much. Wow. Okay. Who wants to answer the question?
John.
Nasagot na dyan si Dr. John. I've heard him answer this question before.
John eh. Ikaw na, John. Sige na, ikaw na.
On the pasaway allegation.
Part of your thesis defense, John.
Susie, do I get another diploma after this?
Pwede.
I've answered some of the questions. No? So I disagree that poor compliance is the main factor. No? It's one of many factors. No? Variants, poor contact tracing, isolation, quarantine. So it's multiple. No? And I don't think it's the main factor. Second, I also believe that we should have lockdowns with equity, meaning it shouldn't just be a lockdown, no, but there should be economic relief also, no, for people who need it. No? The question of your last question of how do we improve how do we improve compliance? I think this is where we need more innovation, no? More design thinking processes. No? Initially, it worked. No? People were afraid. People were cooperative. No? Pero as it dragged on, no, there are other concerns. No, became a stronger factor. No, in influencing their compliance. So I don't have a good answer for that. No, pero I think we need to do more or introduce more design thinking processes, no, in the decision making. But we have more answers, no, for this. Well, one easy, maybe not easy, no, but one way we can do it is the more effective masks are the surgical masks and the N95, TF94, no. Pero if government can pay for that, no, at least for people who cannot afford it, no, that's one way to increase the protection right away. Thank you.
Yeah. Go ahead, Toby.
Yeah. I think that I agree with John, and that first of all, you cannot ask people to stay home. without providing subsidies of some sort, right, in cash or in kind. It's just not feasible. Right? I mean, sorry, it makes no sense. The risk of getting the risk of infection is much smaller than the fear of is much smaller than the fear of going hungry or something, right? So you have to provide. So it's not possible to have it should not be done that a lockdown is imposed without that. And if they do without ayuda or of some sort, and if they do that, you already know that there's some, I don't know, flaky decision making going on, right? It's like, I think one of the officials early in the lockdown last year, remember he said, hindi, okay, magutom ng isang buwan, kaya ng Pilipino yun. Diba? Said something like that. And so it was ridiculous. So we can't have that, okay? Second, I know what you're talking about. You're saying that how can we really comply with non-pharmaceutical, instructions like social distancing if they do not provide, if mass transportation is not adequate, right? So yes, okay, you allow work now, but if they're all crowded in buses or whatever, there's not enough. They have to line up for hours to get there. Then that's why we have, that could also lead to another surge, right? So the answer to that is straightforward. Then there must be some sort of public intervention with respect to providing more buses or subsidizing private, the private sector to mobilize vehicles for that matter. You must solve the problem directly, diba? Because if you go around in circles, right, you may not get there. Now, if they cannot do that, right, it's effectively partial lockdown for people who can't get to work, right? And so you go back to the household subsidies, right? So I think, maybe we can't do anything about this surge, and I'm not sure of that, but certainly can we now figure out the next surge, right? So if we already know that this surge infrastructure was bad, health workers were in short supply, etc., then what? Okay, what is it? Do we now, all those quarantine facilities that were built, can they be remobilized or repurposed for, I don't know, intensive care, something? Is there a program, sana better than the contact tracing program, that you can really mobilize people who may be out of work now, right? And repurpose them to be some sort of supplement health worker in some capacity. You know what I'm saying? In other words, you I don't know, pivot or repurpose some parts of your labor force that are now finding themselves without work because the tourism industry is dead and so forth. Can they be somehow used to help relieve the health system? We have to think out of the box.
Yeah, I know I'm not supposed to do this, and I rarely do it, but I'd like to answer the question too, because Toby is very provocative. I mean, I think to help compliance, one of the things the government should do is should make all testing free. If all testing is free, then people will know. They will know if they have to stay home, not stay home. They will do their own contact tracing. Okay, so short of having an improved contact tracing system, if you do one thing, you make all testing free. And actually, testing is not that expensive. It's expensive because it's in the hands of the commercial sector. But if you find a way to test everybody, to make testing available to everyone, people will go for testing. They're going to do that. Now, the other thing is, John is correct. When you make masks and shields free, make that available for everybody. And the third one, of course, is every time you lock down, you should receive something in your bank or your PayPal or whatever it is.
Yeah.
There is no reason to not give people money during a lockdown, because if you tell people to stay home and they have no money, are they going to stay home? They're not going to stay home. They're not pasaway. They're hungry. They have no food. And we Toby just reminds me of many years back, like we were saying, distribution of relief food is very expensive. Kasi yung logistics yun ang laki eh. Pero if you just put cash, you give people direct cash, okay? They will comply. I don't think our mga kababayan natin, hindi ko iniisip na talagang matigas ang ulo nila ganon. Hindi. They need to be capacitated. So I'm sorry I'm giving an opinion, but testing should be 100% free. And I don't know, people are going to get mad at me, but
and we have the money for that, right, Susie? We have, I mean, PhilHealth has a whole whatever stack of money that they are not. Okay, let's not go into that, right? But the fact of the matter is,
yeah, I don't get started on that, right? But
I know that. But what I guess our point is, we can do it.
Yes, it can be done.
So yeah, you know, on the cash, I agree with you. I think there are certain circumstances where, I think in the beginning of the lockdown last year, where the supply chains themselves were disrupted. And therefore, when you have cash and no supply, then it doesn't, you know what I mean? That could be a situation where it should be in kind, right? So there are certain circumstances. Maybe that's not the case anymore. Yeah. So
anyway,
yeah. rather than putting money to building highways or something.
Give people cash. Give people, okay, we are past the top of the hour. All right, sorry everybody, we got excited.
We're getting a little emotional. Yeah.
Yeah, Raymond, we have some we want to answer the questions to the opinion poll. So Raymond, let's go to that and then we're gonna close. I mean, I know we could talk about this for a long time, but we want to honor everybody's time. And Raymond, let's go to the questions and let's ask our guests to answer them.
Thank you, Dr. Susie. For the first question, well, actually, it's the third question in the poll. How much more transmissible is the B117 variant? Is it 26%, 56%, or 76%? Dr. John?
56.
56%. Thank you, sir. So for those who
Do
are
I get the prize?
No, or may have missed it po kasi, sir. That's something that people will appreciate. Thank you, sir. Number 4 is for Professor Toby Monsod. The economy can only recover if the public health crisis is contained. True or false, ma'am?
True.
Okay.
Absolutely. Yeah.
Okay, and then finally, so this is how it goes po kasi they have to hear it from the expert themselves.
Got it. Okay. Yeah.
Then the fifth question would be, which variant of concern was first discovered in the Philippines? Let me call Dr. Cybele for that.
It's the B1. The UK variant was first discovered here, but the one that's from here, or the new variant here, is the P3 variant. But the first variant in general is the B1 variant.
Thank you, Dr. Cybele. May we call on all of our panelists back, and then let's probably ask for their final reminders or messages po addressed to our attendees.
Yeah, Raymond, I think, are we doing the evaluation also, Raymond? I'm seeing it on my screen.
Oh yes, okay. So while they are going through their messages po, no, we ask also our attendees to please fill out or key in your answers for the panel discussion assessment. There are 5 questions, but in the interest of time, just in a nutshell, it's mostly about how much you have learned and how it was delivered to you with regards to the topic. What are the scenarios for the next 12 months for COVID-19 here in the Philippines? Over to you, Dr. Susie.
Sige, thanks, Raymond. Okay, so we're about to close, but we'd like to ask everyone to just give a very short message. And I think the question we want to ask is, what's your advice? What's your advice to all these doctors, nurses who are listening to us right now? What's your advice for the next year, for this coming year? So we'll start with Aileen.
I think coming from all the lectures that we heard today, let us try not to make gatong yung disinformation and misinformation. So, and I think let's leverage yung social media by siguro going to the advocacy groups about proper use of masks, what kind of masks are effective, and how do you clean face shields, etc. And yung mga friends natin, let's try to get drives how to give free masks and free face shields to our less fortunate co-citizens.
Thank you very much, Aileen. Very, very positive message and something that we can all do. Okay, so Cybele.
Yes, thank you again for inviting me here, and to all the fellow healthcare workers, the doctors, the nurses especially. So today is parang fortuitous. Today is araw ng kagitingan. So kayo pong lahat ay magiting at lahat po kayo ay mga heroes. No? We probably don't say it enough to all of you, especially the nurses who have stayed and who are still with us throughout this pandemic. Maraming salamat po. And just hang in there. I'm with you in the front lines. So we just take it day to day. We can do this. This will end. So hang in there.
Great, thanks. John.
Well, I think the first thing to do is continue protecting yourselves, no? Kasi there are a lot more clusters now in hospitals, no? So get your vaccine, no? If you haven't yet, no? I think only half of the health workers have gone to take their vaccine. And then second, no, try to observe yung health protocols, no? Kasi a lot of the clusters also come from health workers coming back to eat together again, no? Pero I think maybe the more important message is we need to get our political leaders to do more and to do better, no? And I think health workers have a lot of social and political capital that they can use, but have not yet maximized, no? I think we need to all speak up, no, and get government to listen. Thank you.
Thank you very much, Toby.
Same as everyone else. All I can say is please keep safe. We need you. Thank you. I wish we did a better job in terms of resource allocation and prioritizing, and I hope we can do and I hope we can push so that moving forward, investments are in the public health system led by you will really be made rather than in anything else. So I think from an economic viewpoint, it's our economic managers, I think, that have to come around in that sense as well. Sorry, but we'll keep on trying. We'll keep trying.
Yeah, thank you very much, Toby. Okay, so we have a closing statement and a bit of a summary coming from our Executive Vice President for UP, Ted Robosa. Ted, over to you.
Thank you very much, Susie. And it's, you guys always amaze me. It's the 47th episode of this. And the first one was a blockbuster, and each one continues to be a blockbuster on top of the other one. And for all the people that are here in this webinar, these guys that work for this, they prepare a lot. They think about this. They choose who to bring in. And every week, every Friday, I am impressed with the level of information that you have been able to deliver. Today is no different. And today is more auspicious, and Cybele already talked about it. It's something that happened on April 9, 1942. That was 79 years ago. And what happened then? There were 78,000 soldiers that were fighting for this country. 66,000 of them were Filipinos. 12,000 of them were Americans. And they were fighting, and the Filipinos, what did the Filipinos say? No, we're not gonna surrender. Diba? Bayang magiliw hanggang mamatay. And they were ready to fight to the death. The Filipinos wanted to fight to the death, but the Americans couldn't take the number of deaths that would happen. So the Americans decided that they surrender. And they indeed surrendered. And we commemorate that day of surrender. But that surrender saved many lives, although what followed was a death march. The Lieutenant General of the Japanese invading force, Lieutenant General Homa Masaharu. He didn't know what to do with 78,000 prisoners. So he walked them all the way to Capas, and people that were weak or sick or tried to escape were killed or bayoneted. And it's amazing how many people died. 600 American soldiers died on that death march, and 5,000 Filipinos died. Almost the same as the number of deaths probably we have here in COVID. But the interesting thing is, eventually they were able to execute this lieutenant general for war crimes. I'm not saying we should execute our government officials, but definitely there is a lesson to be learned there. Filipinos never give up. Filipinos always keep fighting to the death. And I'd like to thank all the speakers led by our economists, our epidemiologists, our infectious disease specialists, our evidence-based medicine pulmonologists who described everything to us. Professor Toby Monsod gave us all the points of view from the economist. I will counter by saying my rebuttal as a health professional. Well, the economists never invested in our health system. We've been fighting for a higher investments in health system. And we as doctors, I worked in PGH for many years as head of an ER, that is very similar to the situation most ERs are actually having today. And we tried to work it out with the meager budget that we have. I think what's important is a lot of what she said, I agree. Capacitate the health system. The way to fight this pandemic is really to capacitate the health system. And I heard this as well from Professor Pernia. He said, health and economics, we shouldn't be afraid to spend for healthcare, and we should invest. We shouldn't spend for it. It is not an expenditure. Health is an investment, and it is not an expenditure. John Wong, Professor John Wong, talked a lot about data and epidemiology. He has been guiding the IATF with his EpiMetrics group. And without his analytics of all the data, we probably will be in the pansitan. But I think all his analytics are on point and describes exactly where we are. And he contributed 3 things. He said, where are we? How did we get here? And where are we going? And he gave a lot of suggestions. Like me in the National Task Force, I give plenty of advice, but I don't know if the advice always falls to deaf ears. And here, some of the advice that I say have been actually echoed by our experts here in this particular period. So thank you, John Wong, for those nice contributions about how to really fight an epidemic. And we value that. We value your comment on systems thinking that said, if you have a problem, again, very similar to what Professor Toby said, you need systems thinking to solve a systems problem. And it's not so different from what our economists actually said. Then there's Cybele, who's in the front lines, in the critical care and infectious disease front lines, and talked about how it is really out there. And I can commiserate with her. I'm glad I'm not doing any more clinical practice, because I'd be shouting my head off in an emergency department. That was exactly how she described. But she described several things that are important to me. The Swiss cheese model, that solutions to us must be layered, and that we must continue to have all those layers in place to protect us. And that misinformation and science are very important. And she coined the term that's very, that caught on, the virus economics. I think that's something that needs to be written about. Aileen, in the end, actually impressed me with her quotes. I didn't realize Aileen was a wise woman with all these quotes. She started with the Cariño Brutal that she didn't know how to translate, looking at the forest instead of the trees. She looked at the solace and the big picture that John Wong was able to show. And quotes like, knowing yourself is the beginning of true knowledge. Quotes like, science is the great antidote to the poison of enthusiasm, and what's the other one? Of enthusiasm and what do you call it? Superstition. Superstition, correct. And she demolished a current conversation. Some politicians want to give away a current drug, and she demolished the evidence for why these politicians are so passionate about that. And she said, in God we trust, in all the rest, we need data. In the end, I'll talk can say my favorite quote because people were throwing on their favorite quote. My favorite quote when I was studying abroad was I studied disaster medicine, and what was told to me was that we are in the information age. We are swimming in oceans of data, and that data needs to be organized to become information so that it can flow to rivers of information, so that the rivers of information can be used in lakes of knowledge where we get our droplets of wisdom. Thank you very much for joining us this afternoon. Maraming salamat.
Thank you very much. It's Dr. Ted Herbosa, the Executive Vice President of the University of the Philippines and also Special Advisor to the National Task Force for COVID-19. Okay, so next week, next Friday, we have an exciting discussion. And the topic is facts and fiction on COVID-19 prevention and treatment. And we actually might talk about some drugs that we are not mentioning right now because we feel like if we talk about it, we give it more, it's like you're giving more attention to it. But we will talk about facts and fiction. And so we're going to address misinformation. And we're going to have Dr. Isa Alejandria, who again is the president of PISMID, the Philippine Society for Microbiology and Infectious Disease. And we're going to have a couple of infectious disease specialists. Hopefully, we also have somebody from the Department of Health. And I've seen this in the chat. They're going, should we invite someone from the Department? Okay, we will. But I can't announce yet who, because I might get into trouble again by announcing. I don't know if confirmed yet. But we do have somebody invited from the department. Huh? I can. You can announce it. It's confirmed. Okay, so we will have Beverly Ho from the Department of Health. Okay, so Raymond, over to you.
Thank you, and thank you for that. It was a way, what a way to wrap it up. Sabi nga po ng isa sa ating mga attendees sa AVP TED. I will not give my quote because we are over time. But we'd like to thank everyone who is watching us in the live streaming links, YouTube, Facebook, who are still with us here in the Zoom webinar. For those who will want to, again, retest their knowledge and try to understand, we are sharing the poll results as you are seeing here and the answers to the questions po as relayed by our experts. So again, next week, facts and fiction on COVID-19 prevention and treatment. Hope we could see you. Lahat-lahat po kayo ulit next week po, Friday, 12 noon to 2 p.m. It's a date.
Okay, together, let us stop COVID deaths.
So keep safe, keep healthy, and see you online.
The enemy remains unseen. I'll keep your hand in mine. Let's say a prayer one more time. I know you long for home, but I am here, you're not alone. I'll stay with you until the coast is clear. The others pain before my fears, the others laugh before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? Oh God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. Just look into my eyes and say his name to realize it's fine to be afraid. Just hold on to the word he gave. This time will come to pass, 'cause this salvation's made to last. He'll carry you to see the break of day. The others pain before my fears, the others laughs before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. faint before my fears. The others laugh before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'll keep my word, your word is mine. The others vain before my fears. I'm pushing on despite the tears. Please take us through another day. Just hold my hand. I will hold the line. I will hold